Thank you for joining Breast Cancer Care WA for our webinar series on breast cancer, sexuality and menopause. I'm Emily Wilson, one of the specialist breast care nurses here at Breast Cancer Care WA. We have Dr. Lesley Ramage with us today. She is a women's health GP that specialises in the management of menopausal symptoms. She works in the private and the public health system to assist women with menopausal management, and she has a postgrad diploma in women's health. Lesley's going to present on medical management of menopausal symptoms today, which is quite a tongue twister. Once again, if you've got any questions, please write them down on the right-hand side of the chat, and we'll get to them at the end of the presentation. Thank you. Okay. Now I should be able to...
Okay, all right. So this is my first webinar, so I hope I don't embarrass myself. And thank you for your invitation to speak, Emily, and your introduction. So I was just going to give a little bit of background about myself. As Emily said, I'm a GP. I've worked at the Menopause Symptoms After Cancer Clinic based at King Eddie since 2007, although the clinic's been running almost 20 years now. It's the first of its kind and the only public funded menopause clinic in WA. I also hold some private practice commitments, but essentially I care for and love chatting with women who've had a previous diagnosis of cancer. And I have no disclosures. Nobody gives me lots of money to do what I do. So I've got some aims. And firstly, I thought what would be useful would be to actually look at what is menopause, what are the implications from breast cancer treatments with regard to menopause? What are some of the symptoms that women experience? What may be some of the consequences that we experience? And these may be both early or late consequences. Importantly, some management options, and hopefully at the end, some useful links to give you the tools and knowledge to be able to navigate the right path forwards for you. Okay. So menopause, as most of you or some of you will probably know, it means the end of the reproductive life. We have very few eggs left in the ovaries, and this results in low estrogen levels. And we think that it's the low estrogen levels that are largely responsible for many of the symptoms that women experience. A common feature of entering menopause is that periods will become erratic and ultimately stop. And in Australia, the average age is around about 51 to 52. Some of our sisters from Asia might experience menopause a little bit earlier. Sadly, we know that symptoms can go on for many years, both before and after the last period. And in speaking to lots of women, we know that up to something like 80% of women will have some degree of bother with their symptoms. And about a third of these women will actually describe their symptoms as being severe. So what has this got to do with breast cancer? Well, apart from normal life and menopause, treatments for breast cancer can also, influence the onset of menopause. And firstly, we've got things to consider, such as chemotherapy, particular regimes that contain cyclophosphamide or taxanes have an increased likelihood of bringing the onset of menopause. Under the age of 40, if a woman is diagnosed and treated with chemotherapy under the age of 40, she has roughly a 40% or up to a 40% chance of her menopause being permanent. Over the age of 40, due to diminishing ovarian reserve, this factor actually increases up to 70 to 90%. And even if periods do return, we know that women are going to enter menopause earlier than their sisters in the general population who don't have chemotherapy. Another reason why ladies may experience menopausal symptoms is if part of the treatment involves shutting down the ovaries or ovarian suppression. And this is usually or exclusively offered to ladies who haven't gone into menopause and may be part of the breast cancer treatment itself, or it may be considered to protect the ovary from the effects of chemotherapy with the hope of preserving fertility in younger women. This requires a monthly injection, and we think possibly reduces the risk of early menopause by almost 50% or 44%. There are other treatments that most ladies are going to be familiar with, particularly if they've had hormone receptor positive breast cancers. And these are tamoxifen, which is prescribed both for pre- and postmenopausal ladies. And this is it's got a fancy term. It's called a selective estrogen receptor modulator, or I call it an estrogen receptor blocker. So it doesn't actually stop your body making estrogen, but it actually sits in the estrogen receptor and stops it being used by circulating estrogen. Another group of medicines that, again, women may be familiar with are the aromatase inhibitors. And these are really for use only in women who are in the postmenopausal state or who are undergoing ovarian suppression. And these medicines actually block the production of estrogen. So estrogen levels tend to be lower in women who are prescribed and take aromatase inhibitors. Sadly, a common cause of women experiencing menopausal symptoms are the fact that they might have to stop hormone therapy. So women who are prescribed hormone therapy for relief of menopausal symptoms are told to stop and really stop quite abruptly their HRT upon diagnosis. We don't know if this is the right thing, whether we can wean off, but generally women are told to stop abruptly. And finally, there's another group of ladies who are flung into menopause by undergoing surgical removal of the ovaries. And this may be as part of breast cancer treatment. If women are really tired of Zoladex injections, they're quite monthly injections, they may choose to have the ovaries removed. Or it may be as part of a risk-reducing operation if a woman is found to have a gene fault such as a BRCA1 or a BRCA2. So many reasons why women can experience menopause in association with breast cancer treatments. So this slide is actually taken from our clinic at King Eddie's, and one of our registrars has done a research project looking at this. And what we can see, we've got sort of like about 10 main symptoms, and our top 5 are things like the hot flushes and fatigue, difficulty sleeping and sweating at night. I'm not sure if I'm able to move my little picture a wee bit to one side because I can't see all that, but if not, don't worry. And this is important because we will look at this when we as the talk proceeds. So I guess a question that a lot of women ask me is, what actually is a hot flush or a sweat? What's going on in the body? And so this is a very simplistic cartoon of what we think is happening. And so on the left of the slide, under the asymptomatic block, we've got this rather large thermoneutral zone, and this allows us to live in a variety of temperatures. And when we exceed our comfort zone, if we're too hot, we will start to go red in the face. We will start to sweat in an effort to cool down. And if we are at the other end, so the lower end, the shivering threshold, we tend to get goosebumps and shake, and we get blue lips and blue ears. So that's in women who are asymptomatic. When a woman is in menopause, it's as if this comfort zone is narrowed significantly. And so the areas where we were comfortable once upon a time are now not comfortable for us. And so we have an increased tendency to want to lose heat. And this may be, say, by sweating, by flushing. Some women feel they want to go and rip their clothes off. And similarly, at the other end of the spectrum, we may get cold. Phrases like, I just can't get warm, I'm chilled to the bone, are less commonly reported, but nevertheless very important. So that's a little bit about what we think is going on in a hot flush. And I think, if my memory serves me right, please don't worry about this slide. It's a very, very busy slide and is there to remind me to try and describe what's going on in a hot flush. And it might sound a little bit disrespectful, but in fact, a lot of the hot flush goes on in our head. So in the center of the slide, we've got this bubble saying the thermoregulatory center, which is based in a certain part of the brain. And then we've got these arrows feeding into it. And if you can make it out, we've got the American, so norepinephrine, which is noradrenaline. We've got serotonin and estrogen and a variety of other brain chemicals, neuropeptides and all sorts of funky things. And really, all these things play a part in triggering a hot flush or a sweat. And guess what? There's even more. This is work which, again, looks very busy. Please don't worry about it, but it is going to be very useful, just having a thumbnail idea of what's going on in our brains when we're looking at treatment options later on. So I'll whiz past that, but just be mindful that a hot flush is a very, very complicated recipe. So symptoms can vary. There is a variability, as I said at the outset. Up to 80% will have some degree of bother. 30 to 40% may have severe symptoms. I find that symptoms are generally more severe if menopause is brought on abruptly. So if a woman has her ovaries removed, we get sudden withdrawal of estrogen. Symptoms tend to be more abrupt and more intense. There may be factors that are related to the type of cancer, to treatment regimes. And then there's the individual factor, which include a genetic predisposition. There are many genes now that are being associated with our menopausal responses. And so, we sometimes see that women, their family history is rotten for menopause symptoms. They've inherited this tendency to have a bad menopause. So that can play a factor in here. Also, age of diagnosis can be very relevant. If a woman has pre-existing health issues, that can play a factor in the severity of her symptoms. We know from population studies that smoking, sadly, has a negative impact on symptoms, and carrying a little bit too much weight can also be relevant. When we're looking at distress and menopause symptoms, again, it's not surprising that women who are generally well supported, they've got good quality of life, good friends, good partners, tend to have a more friendly relationship with the symptoms than women who are really struggling. So there's lots of factors that go into, I think, determining the severity of a hot flush. So I touched on earlier some of the consequences of menopause, and particularly in younger women, fertility can be a huge concern. We know that the benefit of Zoladex on fertility is unclear, and that if women do have the opportunity to undergo egg freezing or embryo freezing prior to treatment, this is desirable. However, there may be timing issues, availability of the relevant specialists, or even affordability concerns. At the moment, freezing of ovarian tissue, whilst you may read about it in the women's magazines, is still probably quite experimental and not a given. There are those ladies who are going to have concerns about becoming pregnant after the breast cancer treatment and diagnosis and treatment. Some ladies will have to rely, sadly, on donor eggs or donor embryos. Some women will consider adoption or fostering, or even a child-free life. So fertility is a big concern. Similarly, contraception is an issue as well. And after a breast cancer diagnosis, we generally would support non-hormonal methods, so copper IUDs, condoms, other barrier methods. If fertility is really not required, then perhaps a vasectomy in the male partner. Cognitive concerns. I find this a huge concern, which can be both a factor in menopause and I think exacerbated by cancer treatments. I was looking at some data on this and found that in one study, in fact, pre-treatment cognitive concerns were present in about a quarter of women. There was an added insult from certain chemotherapy regimes in terms of short-term memory, recall, the impact of lower estrogen on brain function. We become the masters of making lists, post-it notes, going into rooms, forgetting what we're doing. This is also exacerbated, I think, by endocrine treatment or continuing treatment. And the two in combination, I think, can have a significant impact. And I think it's really important that women are aware of this, because I feel a lot of women do try to get back to life completely as normal after a diagnosis. And I think they sometimes maybe put themselves under a bit of pressure. So I think a little bit of information around this and acknowledgement and acceptance is really important. Weight gain. I think this is a very common problem. The literature tells us that weight gain after a diagnosis of breast cancer is roughly up to 5 kilograms. I think it's often a lot more. I think it is multifactorial and can come from the inactivity that may be associated with chemotherapy or feeling unwell. Certainly the hormone changes, I think, play a big role. Maybe as a result of chemotherapy, we eat differently, things taste differently, we don't like things that we once did. I think weight gain is incredibly distressing for women. I've yet to see a woman who is thrilled at the thought of putting on weight. And I also think it's badly managed. And I think that deserves attention in its own right. In terms of cardiovascular events, we know that women who are diagnosed with breast cancer are at a slightly increased risk of developing cardiovascular disease in later life, and this may be chemotherapy related or radiotherapy related. If younger women are placed into menopause, they're going to spend longer on this planet to become or to acquire cardiovascular disease. And so again, it's certainly worth being aware of. I'm aware that there's a whole speciality of, I suppose, oncology and cardiology or cardio-oncology is now becoming a subspecialty in its own right. But I think we've got to be actively looking for this and guiding women moving forwards. I hope we don't get bombed. Here we go. Bone health. This is, again, another hugely important area. Bone health, to me, means bone loss, leading to certain medical terms. So osteopenia means bone thinning, and osteoporosis means actual loss of bone to a significant degree. It can occur for several reasons, but usually low estrogen. So we know that the aromatase inhibitors, because they lower estrogen levels to a significant point, are quite relevant. And tamoxifen in premenopausal ladies can have a negative impact on the bone density, whereas in postmenopausal ladies, it can be a little bit bone protective. The greatest loss is found in younger women who are having ovarian suppression with an aromatase inhibitor, but inactivity and dietary factors may also be contributing factors. And this is a very poor slide. The picture on the right is supposed to depict healthy bone, and I think you can see there's lots of cross links and lots of bone struts interacting with each other, whereas on the right, the picture looks significantly bare, and this bone is fragile, and so normal everyday activities are going to maybe not be as well supported by a thinning bone. Okay. An area that I think, and we will come to this in more detail, are the impact on vaginal health and sexuality. And I'm aware that Helena has spoken to this earlier. So in my world, vaginal health is also got this, it used to be called atrophic vaginitis, which is a terrible, terrible term, and has now got this equally terrible term of the genital urinary syndrome of menopause. Go figure that. It's characterized by a degree of irritation down below. Women may report itching and chafing. Vaginal dryness can be very important. Women may experience pain or burning with intercourse or in the days after intercourse, and a woman may also develop frequent urinary tract infections. It is really common and underreported, and I think that there are factors in that. I think women may find it hard to bring to whoever they're talking to's attention, and I think the person who's asking the question may not want to ask the questions because it can be challenging moving forwards. They might not know what to do about it. So I think it's an area that we need to talk about routinely and focus on. And again, the causes are largely due to lower estrogen levels, chemotherapy, aromatase inhibitors. Paradoxically, tamoxifen in some ladies will result in a degree of increased secretion in the vagina, and I have met ladies who are actually a bit distressed because they've gone from being dry to wet, and so that we have to manage that as well. And again, a rather poor cartoon. So on the left-hand side, we have a picture of ovaries producing estrogen, and the little cutout section is showing the impact of estrogen on the vaginal wall. So it's moist and thick and elastic, whereas on the other side, getting my left and right mixed up, I apologize. On the other side of this slide, where we have low estrogen, we can see that in the pictogram there is thinning of the vaginal skin. It is less elastic, more prone to trauma. And gory pictures, spoiler alert, if you don't like gory pictures, look away now. Okay, so on this side, which is my left, we have a lady with a premenopausal vulva, and we can see nice pink, moist looking, bulky looking skin. And on the other side, a lady in menopause, which is the polar opposite. This is a quote, and I stole it from the MD Anderson Cancer Center in America. And this is where I usually meet women. So, in my role, although I do work in a breast cancer clinic, I'm usually in my initial engagement with women is usually after chemotherapy, surgery, radiotherapy. I guess I shouldn't be politically incorrect because I may want to be invited back, but I think it's a no shit moment, to be quite honest. And I think this phrase sums it up really, really well. And I suspect many of you feel similarly. Okay, so I might leave that there for you to have a read for a moment or two. And I think it's relevant that it's the quote says it's these menopausal changes are not the breast cancer or immediate effects of treatment that interfere most with your quality of life. And I've spoken to lots and lots and lots of women. Treatment's challenging, but it has a beginning and it has an end. Life after treatment, goes on and on and on. And this is where we're trying to make a positive impact. Okay. But I guess the question is, how do we assess distress? How do we assess symptoms? This is, I hope you can read it. This is something that I've stolen from my clinic at King Geddes. This is called the Green Climacteric Scale. And basically, it's a series of questions looking at various parameters in a woman's life. And she's asked to grade them from not at all the way up to very severe. And this is useful, I think, as an initial baseline, because then, depending on how we progress with management options, we can hopefully see some benefits for our interventions. And even when a woman says, look, I'm having a really rotten time, if you go back to day one, you say, but look how far you've come. You're doing a good job here. So that I think is very useful. Another tool which I suspect we don't use so much in our clinic, but I really love, because I think just measures distress, and it's really holistic because it's looking at life and what is relevant for women. And I was chatting with a young woman yesterday, and trust me, the life events that are going on around for her are huge and undoubtedly are going to impact on her menopausal symptoms because of the associated collective distress. So I think these are very useful tools to use. Maybe if we can come to some management options. I've got some, I think rules of engagement when we're looking at options for women, and I think they're quite good ones. I think that anything we do should be safe. I think it should be based in good evidence rather than hearsay or wannabe. I think it should be available, or they should be available. I think they should be affordable, and they should be acceptable to the woman. And that's going to vary on an individual basis. I think it's unlikely that we are going to find one size fits all. Now, again, this is the go-to slide. What do we do? I split the slide into two parts. There's the pharmacological side. And again, I'm not going into this in too much detail, but I'm very happy to answer questions. And a non-pharmacological side. So on the medication side, we've got a variety of different medication options, which are all clinically proven to reduce menopausal flushes and sweats. They all work better than placebo. They all work differently, and they all have different, I suppose, levels of efficacy. For instance, you can see under the abbreviations SSRI, which stands for selective serotonin reuptake inhibitor. This is an antidepressant. I would rather call these anti-hot flush drugs, because I think this is a huge stigma for women. Many women do not want to take antidepressants because they don't like the stigma associated with it. However, they're often very effective. So remembering those horrible slides I showed earlier about what causes a hot flush, this is why we have this range of options, because we can pick and choose from this either singularly or in combination, to try and get the best outcome for that lady. The area that I'm really, really looking forward to in the next 2 or 3 years, just bring it on, are the last classification, which you can read there as neurokinin 3 receptor blockers. These are in phase 3 trials at present. I'm desperate for them to come to Australia, and I'm hoping to speak to some very influential people to see if we can get some over here, because they really do seem to be very, very effective, highly efficacious, low side effect profile, but we're not going to have them for the next 2 to 3 years. So it's a bit like you dangling something and then saying you can't have it. So I feel a bit naughty about that. But looking at the non-pharmacological options, again, in speaking to women, many women are fed up with drugs. They're done, they've had chemo, they've had all sorts of things. They want to rest from drugs. And so I think it's really useful to look at what is available that's not in a pill form. And so we can talk about the healthy living. So, having a good diet, not smoking, not drinking too much. There is increasing evidence that cognitive behavior therapy, when administered by a clinical psychologist or a good counsellor, is highly efficacious in reducing menopause symptom-related distress. And I realise there are implications for provision with that, but I think we need to be aware of it, and we need to make a good case for it. One of my colleagues recently did a literature search looking at other non-pharmacological options, and in fact found some local evidence for things like hypnosis, yoga, and acupuncture. They are not for everybody, but they have been proven to work in certain circumstances. So that is my horrible slide, another horrible slide. Basically, and I don't know if you can really see, but basically these wonderful drugs, when they come, are going to knock out one of those neurons, stop it firing, and quieten down our hot flushes. And I think this is going to be game-changing for so many women. I really can't wait for this to come. Now, I did, in my list of options there, you note I didn't put exercise. Exercise actually doesn't help menopausal flushes a great deal. However, it's really good for a lot of everything else. So we know that exercise is good for bone and heart health. It is excellent at helping with mood, fatigue, and quality of life, and also reducing the risk of cancer coming back. I've put up there a sort of promotion for the Variability clinic run through ECU, but any exercise is better than no exercise. And I think if we can encourage women to incorporate this as part of their new life, then that gets a big tick of approval. I hear that in the UK now, whilst women are awaiting treatment, they're actually being sent on exercise courses. So, I think this is really forward thinking from the NHS. There are a lot of other, I suppose, unproven therapies, and I'm aware that placebo effect can be useful for some women. However, when we look at evidence, hard evidence, there seems to be very little evidence to support the use of phytoestrogens, of ginseng, St. John's wort. And I think we have to be careful if we are taking any complementary therapies that they don't interact with our existing prescribed medicines. In particular tamoxifen. There are certain medicines that will interact with tamoxifen, and we don't really want that. We can see that for evening primrose oil, there's only been one clinical trial, and it really didn't show any benefit over placebo. Vitamin E, we used to prescribe through the menopause clinic, but really we found that the overall reduction in hot flushes was really quite minimal. I do have some ladies who found it useful, so it's not likely to be harmful. It may be helpful, but it's not something that we promote. Sadly, and this, I find this a very challenging area, some ladies are saying, look, I need my hormones back, my quality of life is really poor. So at King Eddie's, we hold a multidisciplinary meeting for interesting / challenging situations, and we have the conversation about is hormone therapy appropriate for the lady. And I don't want you all to go rush off and start pestering your GPs or your oncologists saying I can have hormones, because it really is definitely not that simple. But I think there are circumstances where it has to be considered as an adult discussion. and everybody goes into it with their eyes wide open. But it's not something that we push, and certainly something that we don't recommend as a first, second, or third line. However, when we're talking about vaginal health, slightly different story here. And as you can see, that getting wet after breast cancer can be tricky. So Helena may have touched on this previously, and I'm quite sure that Judith next week will also touch on this. So we would probably look at a range of personal lubricants, such as Pure, which is a silicone-based product, non-hormonal containing moisturizers, such as Replens or Acid Gel. Olive B is a reasonably new one that a lot of physiotherapists are using. And more recently, we've started using hyaluronic acid, which is a naturally occurring thing. Pelvic floor physiotherapy, I find an invaluable tool, particularly when pain or discomfort with penetration can be part of the problem. We basically need to learn how to relax the pelvic floor muscles. And trust me, women like Judith are worth the weight in gold. So tune in next week. It will be worth your while. I do think that specific sexual wellness counselling is also vital. And unfortunately, we're starting to send women now off on many, many pathways. You know, we've got the psychologist and the physiotherapist, and it's becoming a little bit messy. Sometimes a lady has to consider a change of endocrine treatment. So in talking with her oncologist, if all else is failing, you know, sometimes the oncologist will say, okay, let's switch to a different aromatase inhibitor, or perhaps let's trial some tamoxifen, because we don't want to compromise your care, but we want you to have a good life as well. I think you could probably see there under hormones, I've put a little asterisk, and then following down the dreaded word estrogen. So if a woman is struggling big time and all the non-hormonal options are not meeting her needs, and she is prescribed tamoxifen, I am very comfortable phoning her oncologist and saying, look, you know, Frida's, you know, struggling. What are your thoughts on us using some Avestin? And I would say 9 times out of 10, the oncologist will be on board with that. And we can use that with safety. We do struggle, however, when ladies are prescribed aromatase inhibitors because of the way they work. And most oncologists are going to be a little bit uncomfortable with that. And so that warrants a little bit more discussion. You can see in a slightly lighter shade of grey, I've put another 2 options. These are not available in Australia. One is called DHEA, which is a pro-hormone, and the other one is called ospemifene. And ospemifene is a bit like tamoxifen. It actually is a selective estrogen receptor modulator, and in theory should be useful for vaginal dryness, although to my knowledge we've got no data to support its use in ladies who've had breast cancer. So I've put them there because they may become relevant to us in Australia in the future, but they're not here at present. And similarly, laser treatments, and there may be ladies out there who've undergone the Mona Lisa touch or one of the vaginal laser resurfacing techniques. Again, I think the evidence is still a little bit lacking in this area. We are awaiting the results of a big multi-centre trial, which should be published at the end of the year. So I think I don't push this with ladies. It's also quite costly. It's about $3,000 and requires 3 treatments. And to my knowledge, we don't yet know the long-term impact, long-term safety effect. And I'm just hesitant to recommend that at present, but watch this space, nothing set in concrete. This is a rather lovely picture of the vaginal skin, and on that side, the left side of the screen, this is a lady who has not had estrogen for some time. And I think you can possibly see that there's a rather thinnish top layer, and then a dividing woolly layer, and then a bottom layer. And then when this lady's had estrogen for a couple of months, the top layer is thick, it's more vibrant, and this is exactly what happens in the vagina. This also forms a physical barrier to us being able to absorb more estrogen. So, you know, it's actually a self-fulfilling prophecy. It's actually really useful to be able to use estrogen when we can, provided it's safe to do so. this is a little bit tiny. So I thought I'd try and put it all together and looking at what options do we have. So this was a recent publication in the Lancet Oncology, so a very good journal. And I think you can see in the inner circle, there are several domains. So we have hot flushes, we have fatigue, musculoskeletal symptoms, sexual dysfunction, and weight gain. And then on the outer circle, we've got different parameters of options, and the darker the color, the more useful that option was. So I think you can see if we look at fatigue, for instance, which is the purple, then at about the 4 o'clock position, cognitive behavior therapy actually scores really well for helping with fatigue. If we look, for instance, at hot flushes, then at the 2 o'clock, some of the medications there are again quite useful. I'll magnify this up in a bit more user-friendly slice. So this is taken from the same paper. And if we look down the main column here, we'll look at treatment options. So we've got antidepressants, anticonvulsants, bladder medicines, switching adjuvant treatment, vaginal lubricants going down that column. And then across the top, we have symptoms such as hot flashes, sexual dysfunction, weight gain, and I presume these are, can't read it. I've got myself in the way there, that little blot there. Thank you, I can't move myself. Thank you. So if you look across the board, in fact, CBT seems to score very highly across all parameters. Whereas vaginal lubricants and moisturizers are really good in sexual dysfunction, but are not going to do a lot for musculoskeletal pain. And I think these, again, might be something for you to take on board when you're looking at what might be appropriate for as an acceptable option for yourselves. So when we looked at our studies from King Eddie's, the first column shows ladies at the first visit, the second column shows a follow-up visit. And what the interventions were. And we actually found that we did reasonably well in reducing hot flushes, fatigue, poor sleep, sweats at night, and less so in sexual function domains, which was very disappointing. We had some improvement in anxiety and difficulty concentrating. So obviously there are unmet needs there. I think partly this is also due to COVID and phone calls. So we weren't actually able to see ladies, and it's much better to assess these women, I think, on a face-to-face basis. This is another paper looking at Australian data, put together by my colleagues, Martha Hickey, Christabel Saunders, Paul Cohen, and Michelle, so I've just gone blank, who's a clinical psychologist. And this is looking at 3 symptoms: menopausal symptoms, sexual function, and mood. And then who women were getting their help from. And I think it's really quite damning that something like 70% of women were actually looking at managing themselves with regard to sexual dysfunction. A few sought assistance through physiotherapists or sexual counsellors, but the lion's share of women, particularly in this domain, were not receiving any help at all. I think overall something like 3% were receiving care from a specific menopause symptoms after cancer clinic, which is really quite damning. When we're looking at satisfaction with women's care, again, I'm not impressed. 30% are happy with management of their menopausal symptoms, only 12% are happy with sexual wellness. Pleasingly, about 60% were happy with their mental health, but a lot of women, nearly 70%, were not accessing help with their sexual wellness. And these were some of the comments that women free typed in this project. It gets brushed off. I Googled most of my help myself. I had to go to numerous doctors. One doctor even said I should stop having sex. A few warnings should have prepared me better. I thought it was all my fault. And I appreciate that, there's a lot of information to be garnered. I don't know when is the right time to share this information, but these are quite distressing. So let's share the love or the cost, because cancer is expensive. We all know that. And if I ruled the world, I would have a one-stop shop where we had all the lovely providers and women can pick and choose, like kids in a lolly shop, what they need. But we don't have that, and I'm hoping maybe some rich uncle will leave us a lot of money that will allow us to do it. But I want you to be aware of the use of care plans. So there are two types of care plans, and these are usually organised through your GP. One is a mental health care plan, and that will allow you to access clinical psychology. And I think at present under COVID, we're allowed to get 20 sessions a year. The other option is to ask for a chronic disease management plan, and that will allow you to see people like exercise physiologists or pelvic floor physiotherapists. It is unfortunately limited to 5 sessions across the whole range of allied health professionals, but nevertheless, I think it will help bear some of the financial cost. And women can have both. They're not mutually exclusive. And so finally, where to go? Look, there are, obviously I'll leave this up and you will be able to access it. Cancer Australia have got a really good publication on their website. I was privileged enough to be a GP on the creation of this document. It covers a lot of symptoms, so please go and look at that. The Cancer Council and Breast Cancer Care WA, the Australasian Menopause Society and Jean Hales are free online resources for women. You don't need a medical degree to be able to access that. I'd like to give a shout out to Myra Hunter, who is a UK-based clinical psychologist. She has done a lot of work in this area and has got some online resources looking at managing menopause-related distress. And so please go and Google her, not Myra Hindley, as I always want to do. Please come and talk to us at the MSAC clinic. We currently have a wait list of about 8 weeks. I don't think it's too busy. Happy to see you there. And one of my colleagues, Dr. Manju Ambekar, has recently gone out into private practice. This is another area of expertise of hers. She works at the Menopause Clinic and is happy to receive referrals and may be useful for ladies who are north of the river. And I think that is it. Thank you so much for your time. I hope it's been helpful.
Any questions? Thank you so much. That was absolutely fabulous. Thank you for your expertise in that wonderful presentation. There are a few questions.
Yes, surely.
So I think I've written most of them down. The first one was a little bit about some hormone replacement therapy after breast cancer, which you did. Yeah, you did answer. So we do know that the risk is higher. Is that right?
Yeah, there are a couple of studies. One's called the Stockholm study and the other is Habits, and they're actually amalgamated. They're going back to about the early 2000s. But unfortunately, they definitely showed a 2 to 3-fold increased risk of breast cancer recurrence. Even after Tibolone, which was a product we were using actively in ladies who'd had breast cancer. The study is called the Liberate study, and this actually showed an increased recurrence in ladies with a past history of breast cancer. So we don't rush these products for that reason.
And if someone did want to go about restarting that, what would be the process? They need to see their GP, or
I think GPs will run a mile. GPs are scared. Look, I would encourage women to have a chat with their oncologist, and I accept that some women have been discharged from oncology care. So that can be a problem, but I think I would start off with an oncologist. By all means, we are welcome to have that conversation, but I think it has to be, I call it my big girl conversation. We have to be aware of all the pros and cons, but I think we've also not got to make women feel guilty about the decisions that they want to make about their life. So I would initially start off with an oncology appointment if you can. Don't go to your GP because they'll probably just say no and you'll go back in your shell and wish you'd never dared ask the question, to be quite honest.
Thank you very much. Next question is, can you discuss the risks of pregnancy while you're on ovarian suppression and non-hormonal birth control?
Okay, well, if you're having ovarian suppression, the chances of you becoming pregnant are really, really, really remote because we are giving you an injection that shuts down your ovaries. So pregnancy should not be an issue. Non-hormonal methods of contraception would be preferred. Yeah. So condoms, diaphragms, copper IUD, not the Mirena, not the Kylena, not the Implanon, any non-hormonal method. Is that the question that I answered it correctly?
I think so. Discuss the risk of pregnancy.
So I think the risk of pregnancy is low. If a woman's actually having chemotherapy and conceives, I think there's a very difficult discussion to be had around that.
Thank you.
Unfortunately.
Answers that question. Do we know the proportion of women post-treatment that report cognitive concerns?
Anecdotally, I would say it's very high. I would say it's about 70 to 80%, and even that may be a disservice. I think it's one of the areas of unmet need. I'm always writing letters to employers to say, dear, blah, blah, needs extra time or support at work. And I think women need to be kind to themselves as well.
Okay, thank you.
So I think it's high, yes.
And then the next question is, do you know if the Lancet or any other journal discuss cognitive impairment and what we can do to help manage it?
Not specific. Yes and no. In fact, if you girls out there have access to computers, I would Google the International Menopause Society. They held a really lovely webinar. I think it was last June. It was in the height of COVID, and it was all about survivorship after cancer, and cognitive impairment, sexual function were covered really, really well by international presenters. By all means, access the Lancet article. It's a free publication. So yes, in short, the answer is yes, do your research. But I think the IMS has a very good webinar on that.
Okay, thank you. There's a few more questions.
That's okay. No, absolutely.
The exercise clinic at ECU, could people have a bit more information about that?
Yeah, so I think there are two clinics. One is for men after prostate cancer and another for women after breast cancer. I think they have intakes every so often, and they run a course of 10 sessions. Now, I might have to do my own research because somebody told me the other day that it was only at Joondalup, and I had a feeling it was not. I thought it was throughout the metro area, but it is very affordable and very doable. And the women whom I see who engage generally want to go on and partake in regular exercise, be it in the local gym, community centre, whatever.
Okay, great. Thank you. And someone's asked for the name of the UK person who has a number of apps and resources.
Yeah, Myra Hunter. Myra Hindley, you may remember, was the Moors murderer, and my age gives me away. So she pops into my head. So Myra Hunter, and she's co-written a book with a clinical psychologist. I do have brain fade. I can't remember the clinical psychologist's name, I'm afraid. But she's well credentialed, and I think that there's even a little book. I think it costs about $20, so hopefully won't break the bank.
Cool. Thank you. When does vaginal dryness become vaginal atrophy? And what are the differences in symptoms? And how would someone go about getting a diagnosis?
Very good. I think we use these terms interchangeably. I'd like to think we don't use vaginal atrophy. It sounds so awful. So any symptom, I think, should be seen. You cannot diagnose this over the telephone. I would recommend initially, if you're comfortable, going to your doctor. We've all had pap smears. We might not like them, but we have the cervical screening test. So it really warrants an investigation. I usually look at performing swabs to exclude any infection. But it's about comfort and what you experience around intimacy. So yeah, physical examination, preferably with your GP. If not, get a referral.
Great, thank you. And you mentioned that some people can go the opposite way and have vaginal wetness as well. So what would we do to help manage that?
Yeah, really good question. I think sometimes explanation is all we need. And I think if a lady's spent many years in the postmenopausal state, she's possibly got a little bit used to being a little bit on the drier side. And then if we add in tamoxifen, suddenly we get this wetness. And I think simple explanation that this is, you're going back to what you used to be. It's just that you've not been used to being you for all this time. If, however, it is really bothersome, then again, I would carry out a physical examination. I would always want to exclude infection. Sometimes we can get little cysts at the top of the vagina. So I think physical examination first and foremost, and then plan from there.
Great.
to be honest.
Thank you. Next question is chemotherapy and endocrine therapy and the effect on the liver. Research is now showing that people can get fatty liver with both of those. Do you know much about that?
I know a bit about fatty liver. I don't know a lot about fatty liver and the aforementioned thing, but fatty liver is unfortunately really, really common in the population now. So I can't really comment to that in a meaningful way. Sorry.
That's okay. You've answered everything so beautifully for us today. And probably one of the last questions is, can you tell us a little bit about your role and where you work and how people would go about getting an appointment with you and things like that? Do they need a GP referral or what's the best way?
So I'm a GP. I'm not an ologist. I don't need a specialist referral. So to access our clinic through the Kingeddys, yes, your GP or a breast care nurse, a physio, oncologist, and somebody who can refer. It goes through the central referral service. We triage appointments, and I say we offer appointments. Usually, I think it's about 8 weeks at present. As part of the clinic, we have 2 GPs, 2 gynecologists, a gynae oncologist, and a wonderful clinical nurse as support. We did used to have more team members, but we've had some pruning, so that's us in a nutshell. We like to see ladies face to face, which is the preferred option. I know COVID's been in the way, so we have had to do some phone consults. If from a private point of view, my contact details I think are in the webinar. I'm currently booking up to October now. I'm not. Please, I'm not self-promoting, but I work in a couple of private clinics, so that's another option. Also, my colleague north of the river is very skilled in this area as well.
And do people need a referral for the private clinics as well?
I think it's useful. They can self-refer, but often it's useful, and some, so you don't have to traumatize the lady and going through all the history again. If you can. You've got some knowledge there, and you don't need to rehash stuff.
Absolutely. There's some wonderful feedback there about the menopause symptoms after cancer clinic and how wonderful you are, which I can definitely attest to as well from the patients that I've sent your way.
Okay.
Lastly, any take-home advice for women?
Oh my goodness. Don't accept second best. You've got one shot at life. It's your life. I want you to have the best life you can have, and just because some things are not necessarily readily available doesn't mean we shouldn't strive to achieve them. So, fight for your right, one of those.
Absolutely.
But, let's do the best we can to have good lives. And that's what we're here for, to try and give you the knowledge and some tools to be able to pick apart what is right for you. Everyone's going to have their own needs. But our aim is to improve the quality of life for women.
Thank you. So please don't hesitate to reach out to us.
Yeah.
Thank you so much for your presentation and going through that question and answer session with us today. It's been absolutely wonderful. Your expertise is fabulous. At the end of today, we'll be sending out a brief survey. If you wouldn't mind filling that in, that'd be fantastic. And there'll also be sent a copy of the presentation delivered today as well. Next week, we have Associate Professor Lesley Stafford, who's a clinical psychologist at the Royal Women's Hospital in Melbourne, doing a presentation. And we also have Dr. Judith Thompson, who is a women's health physiotherapist in Perth. So we're really looking forward to those presentations as well. And we hope that you can join us next week. So thank you very much. Thank you.